C-TRIC, who many of you will be very well aware of, and also Research Director in the Western Health and Social Care Trust. So, first of all, I'll just hand over to you, and if you could give a little, as I said, many people are very well aware of C-TRIC and what it does, but could you give a little bit of background, where things are, and what the next steps are?
Thanks. So I suppose C-TRIC started off quite a long time ago, probably more than 15 years ago, and the whole idea of it was to try and bring academics, business and clinicians together, and so, there's a lot of examples of that around the world, but and at a time we probably would have done anything to sort of generate enough finance to actually keep the doors open. But as it's gone on, it's great to see Jennifer there today. We have been an incubator for various different companies, and we have developed a real theme in terms of personalised medicine. So, people like the term personalised because, instead of precision or stratify. And within that there, you have the three partners, where you've got Ulster University as a partner, the local authority in Derry City's Rand District Council, and then the Western Trust. So there are three equal partners in this, and they really come at it from very different angles, ultimately with the goal that you're going to provide better care, higher quality care for patients, and that you're going to be able to attract, high quality people, especially people maybe from here who we do hemorrhage a lot of talent to other places, and we haven't really been hugely successful in bringing those people back in droves. So over the years we've done a whole variety of things in terms of contract research, but I think now we've become much more focused in terms of what we really want to do. I suppose the first objective has been to try and increase the amount of clinical trials that we're doing, both locally but across the entire region. And one of the sort of new innovative ways of doing that regionally is that we want to go out to the community, and particularly the communities that are really hard to reach. In primary care they talk about these deep end communities where they're the people where the clusters of disease actually are, but yet they're not participating in innovation and research so that they can benefit both themselves and the sort of wider population. So through the VPAC program, through PHA, we have been able to secure a mobile research unit to try and go out to those communities across, and it just happens to be that that's going to be housed and managed by C-TRIC and the Western Trust, but it's very much a regional asset. The other thing I suppose, in terms of all the reset aspect of things is, when people talk about waiting lists, as somebody who works as a frontline cardiologist in the Western Trust, when you go down to the A&E departments, you can see the sort of chaos of all of our A&E departments and how they're overfilled. We do have to find ways of trying to tackle that, and there's certainly, a lot of innovative ways to actually do that. And one of the key areas that we're focusing upon is pharmacogenomics, or precision prescribing, where we're actually trying to work out from your genetic makeup how you're going to respond and react to a whole variety of medications. And we know now that if you do that you very significantly reduce the amount of adverse drug reactions, and that has a huge economic benefit in the sense that you're bringing down the total spend, and incidentally in Northern Ireland we spend more per capita on pharmacy than any other region of the UK. So that's a real focus for us, and focus probably primarily in the mental health aspect of things, which probably will be managed primarily by our primary care colleagues. So we want to really link in to try and help them to facilitate, to implement that within primary care, and also then the area of cardiovascular disease, which I make no apology for being biased towards that, but it is a major problem for our society and for society globally. So, you know, there are a lot of medications that we use to prevent stroke, to treat heart disease, to treat peripheral vascular disease, and for the first time probably ever, you know, we're seeing NICE guidance to say that we should be measuring genetic material so that we can actually guide the prescription of medications properly for our patients and for the wider community. So there's a huge cost in terms of the human cost that you're saving, but also the cost that you're saving in terms of that economic benefit. And the most recent sort of landmark study published in Lancet last year shows, you know, really a 30% reduction in serious adverse drug reactions. And that's probably an underestimate because we don't have a great way to capture those adverse drug reactions that occur, say for example in primary care, where you're started on a medication maybe for pain relief and you have a side effect or an adverse effect from that, and you go back to your GP and you never make it as far as the hospital because, you know, it's not required for you to go. But that episode has a cost. That has a health economic cost. It is a cost to you as an individual. And, you know, it may well be with better prescribing that we can then prescribe better for you at a reduced dose or using an alternative. And all we had to do was take a swab from your mouth and put it into a device and then provide the referrer with the appropriate information that allows you then to be prescribed with precision. And I suppose those are the things really at the minute for me that I really do think that we can have. It's low-hanging fruit, you know, because we know the evidence is there, and it's really now about how do you implement that.
Brilliant, that's fantastic. And one of the things I wanted to ask was about the reset plan, and you've covered quite a different few parts of it there in terms of reducing variation and thinking about the kind of more public health side of things. And you mentioned there low-hanging fruit, and so I'd like to ask you, where do you see kind of the key strengths of collaboration are here that would help address some of those kind of really easy to answer questions?
Well, I think that there's a few things, and it sort of goes across a whole spectrum of you know, ways in which you can improve the health of our nation. And I mean, one of the things would be, you know, we've got to have significant buy-in from the HSE and from the Department of Health. And there has to be some sort of innovation program, innovation ladder that's actually going to support those challenges, you know. And with that, there has to be finance that's going to do this, you know what I mean? So, I mean, it is very, very difficult to commission any new service within NHS Northern Ireland as it currently stands. And so you could think it's the greatest idea in the world, and you could have all of the sort of senior support within the various different quarters and the various different stakeholders, but it's exceptionally difficult to implement that. And I think there has to be a real focus and drive to try and map out that pathway and really then succeed in bringing these new ideas through. And probably within the Northern Ireland context, it's an ideal size of a living lab to actually allow you to do that. But it is difficult, and it's difficult. You know, we need industry to try and facilitate this, but then there has to be a certain amount of trust between industry and the health service as a whole. And we also need to have our academic colleagues in both of our universities here in particular in Northern Ireland invested in it so that they can provide the skill sets. And that becomes really important in our data ecosystem, because this is only going to work. I mean, if we were to implement a pharmacogenomic program tomorrow, the first question that the population would ask is, does this actually work? Does it do what it says on the tin? And to really know that, we need to know longitudinal information about our patients. And at the minute, it's exceptionally difficult to do that. And even with the installation of EPIC, where, you know, we've, you know, as a region have spent a huge amount of money, and it's fantastic, but really it doesn't have the capabilities within it as it currently stands to allow us to extract that information and to longitudinally look at it. And there's a little bit of disjointedness between where that data sits, how it then links to legacy data sets, like in the Honest Broker Service through the BSO and the data warehouse that would have been there historically prior to the setup of the Northern Ireland Health Analytic Platform. So those things really need to link together. All of those tools are actually here within this region. Unlocking that and getting the people that are the stakeholders within this here to actually facilitate that and link it all into that ecosystem is going to be crucial. And actually, if it can be done, then it changes the ball game completely, because you're talking about a living lab, 2 million people, and you'll be able to really study and advertise Northern Ireland as a region where people can come here and innovate and do research. Until you do that, and until we get everybody into the room and unlock that, then it's going to be continue to be a challenge.
Brilliant. Thanks very much again. Really insightful here. And one of the things you mentioned there was about kind of industry and the ideas coming up with innovations. Thinking about people who are here today, and we'll be probably speaking to you after. What's the kind of, more than advice, what are the kind of recommendations that you would give to people on the industry side of things when they're coming with ideas? What are the kind of first steps you put them on to kind of set them on to achieve?
Well, I think there's a lot of people out there that have a lot of good ideas, right? Unfortunately, to drive it forward, the first thing that we need is money, and I think it's probably quite challenging within the environment that we currently are to actually get our hands on that money, because health doesn't have that money, and I think that's where, the enterprise, the Department for Economy and Department of Health really do need to become bedfellows in this to again facilitate really good ideas from Indigenous industry and beyond, and to allow, whether it be Indigenous or whether it be foreign direct investment, that they come in and, for want of a better term, it becomes a test bed for people to test their wares within Northern Ireland. At the minute, it's very difficult to do. You could develop something that's fantastic here in Northern Ireland, and you can be quite stifled by the route to actually test it, the procurement exercise that you may or may not have to go through, and really the assistance in terms of that regulatory environment that's challenging as well. And all of it costs quite significant money. And in city deals, for example, we're seeing a mix of deals being dealt with by the Department of Health, and we're seeing deals being dealt with primarily by the Department for Economy, but there's not a huge amount of evidence that the two are working in a cross-departmental way to try and, make life and health science a major theme within Northern Ireland, even though we've had a gigantic investment in our region's terms, in the Belfast deal and the deal that we have in the West, and the subsequent deals with Causeway, etc. It's about how you actually help and facilitate that to happen, because at the minute it's quite difficult. So industry does find Northern Ireland a little bit challenging to get to those stages, and we need investment, whether that's angel investors or challenge funds or collaboration with our wider UK colleagues to try and get this across the line.
Thanks, Aaron. So, one of the things I'd just like to ask finally is we talked this morning about if we were to do this again next year at NICON, and think so in 12 months' time, what are the kind of measures, because all of those things, as you say, are quite complex and lots of things that need to be put in place first. What's the kind of, I suppose, approximate measure that could be in place in 12 months' time to show that things are going in the right direction, or if things are in place that would help move towards some of the things and overcoming some of those quite complex barriers that you mentioned?
That's a good question. Have you got a few hours? I mean, I think there's certain things where you need to have a foundation for, and our data and how it works and how it's needed is really key to all of this. I mean, if you were a major pharmaceutical company and you wanted to come into Northern Ireland, what you'd want to do is you'd want to say to you, can you deliver Sean in this here? You know what I mean? And for you to do that there quickly, you need to be able to screen thousands and thousands of people, plumb in the eligibility criteria, and be able to identify a cohort of individuals that matches that, and then allow that to be, those people to be approached with the correct data governance so that you can then really deliver on that, assuming that you have the capacity and the capabilities to actually do it. If we were to focus just on that area by this time next year, that would be a brilliant way to fulfill what is the direction of our R&D, which is that we expand our clinical trial capability. I mean, as I say, I want to be realistic about 12 months. I mean, there's other things in the background, like the implementation of our secondary use data legislation, which was passed in 2016, by the way, and 9 years on, we still haven't got it fully implemented, and actually there's a few problems with it. So, those sorts of things are absolutely vital for the nation to be able to participate in research which gives them the highest quality of care and makes the place better.
Thanks very much, Aaron. Really appreciate that. Yeah, lots of complexity there. So